Well, so I think CAR T cell therapy and bispecific antibodies can really be considered as complementary. So currently CAR T cell therapy targets CD19 molecule, whereas bispecific targets CD20. At least in the US, CAR T cell therapy is approved in the second line, whereas bispecifics are approved in the third line setting. So in a patient with relapsed or refractory large B-cell lymphoma who's coming in the second line, we typically use CD19 CAR T-cell therapy, since that has been shown to improve PFS as well as overall survival in patients and be potentially curative. In the third line setting, occasionally we do get patients who have not received CAR T-cell therapy in the second line. In that type of situation, both CAR T-cell therapy and bispecifics could be potential options for the patients. But so far, the pivotal trials with bispecific antibodies have shown that it's not yet clear whether these are curative for large B-cell lymphoma, because even at 3 to 4 years, we see that we don't see a plateau in the progression-free survival curve. So at this point, we still prefer CAR T-cell therapy as the preferred option in the third line setting as well. But in the future, we do see that bispecific antibodies are currently being evaluated in the first line setting in combination with chemoimmunotherapy, and they are likely to, if the trials are positive, they're likely to become the standard of care in the first line. In that type of situation, CAR T-cell therapy is likely to be used after bispecific antibody approaches. But because they target different molecules, these could be considered complementary. In fact, at our center, we are evaluating CAR T-cell therapy in combination with bispecific antibody to minimize antigen escape and improve efficacy in these patients. So currently, for patients who are relapsing after CAR T-cell therapy, I think if we look at the potential mechanisms of resistance, broadly we can group this into 3 different categories. So the one group of patients, about a third of the patients relapse because of antigen loss. There's another third of the patients who relapse because of T-cell fitness issues. And another third of the patients relapse because of various tumor intrinsic resistance mechanisms that mediate resistance to CAR-mediated killing of the tumor cells. So at this point, so when a patient relapses after CAR T, we would really do a biopsy and assess for expression of various antigens. So going forward, if you want to improve efficacy of CAR T-cell therapy, I think one way to improve efficacy is to target multiple antigens, and this can be done by specific CAR T-cell therapies. So currently, CD19 and CD20 bispecific CARs, and CD19 and CD22 bispecific CARs, as well as those targeting CD20 and CD79A or B, are all being evaluated in the clinic. Now, to improve the T-cell fitness, we don't yet know what is the optimal way, but what's been shown in CLL is that if patients are treated with ibrutinib before they undergo apheresis, this appears to improve the T-cell fitness and yield a much better CAR T-cell product, and that leads to improved efficacy as well. So one way to do is to use BTK inhibitors, and BTK inhibitors primarily seem to mediate their effect by inhibiting BTK in macrophages and myeloid-derived suppressor cells, and thus eliminate some of the immunosuppressive mechanisms for CAR T. Besides that, immune modulating agents such as lenalidomide and CELMoDs are being explored as combination strategies, but these have been proven to be difficult to administer in combination with CAR T-cell therapy, partly because they also cause cytopenias, and patients who undergo CAR T-cell therapy frequently experience prolonged cytopenias. So currently we only use them in sequential manner. With respect to combination with bispecific antibodies, I think these trials are now ongoing, but so far in the standard of care setting, they're mostly used in sequential approaches. With respect to allogeneic CAR T-cell therapy, there are a number of trials that are currently ongoing in lymphomas. Broadly, this could be grouped into allogeneic CAR Ts, where intensified lymphodepletion is used to improve their persistence and expansion and durability of responses. There's another group of allogeneic CAR T-cells where that use what is referred to as a hypoimmune strategy to prevent elimination of the donor CAR T cells. This is done by MSC class 1 and class 2 knockout, or by introducing molecules such as HLA-E or CD47 overexpression to inhibit NK cell function. The trials so far have shown that allogeneic CAR T-cell therapies are really well tolerated with respect to CRS and ICANS. They're either similar to autologous CARs or more safer than autologous CARs. We don't see graft versus host disease in any of the allogeneic CAR T trials. And with respect to efficacy, we do see that the overall response rate and the complete response rates are similar between allogeneic and autologous CAR T-cell therapy in relapsed refractory large B-cell lymphoma. However, durability of the responses so far has been poor in allogeneic CAR T-cell therapy because we do not see persistence beyond 4 weeks in majority of these patients. So currently, with the current generation of allogeneic CAR T cells, the best strategy to use them is probably in the minimal residual disease setting. In fact, one of the companies has launched a phase 3 randomized trial where patients with first-line diffuse large B-cell lymphoma, after undergoing standard chemoimmunotherapy for 6 cycles, are screened for minimal residual disease by a phase-seq assay. And if they are MRD positive, they are randomized either to observation, which is the current standard of care, or to an allogeneic CD19 CAR T-cell therapy approach to see whether that would improve event-free survival. But in the future, to make allogeneic CAR T-cells even more effective, we need strategies to better overcome immune rejection and improve their expansion and persistence and thereby durability of responses. So this is actually my 4th visit to Korea. I've been to Seoul now. This is my 3rd visit to Seoul. I've been once to Busan as well. So I love coming here. So I love visiting all the cultural places, and the people are very friendly, and I love the food. This is my first visit to the Korean Society of Hematology conference, and I see that it's got diverse audience. They have outstanding speakers as well as both from Korea as well as outside Korea. Today's morning plenary lecture was outstanding by Dr. Terafi, and I'm looking forward to attending some of the lymphoma sessions. So this is actually my 4th visit to Korea. I've been to Seoul now. This is my 3rd visit to Seoul. I've been once to Busan as well. So I love coming here. So I love visiting all the cultural places, and the people are very friendly, and I love the food. This is my first visit to the Korean Society of Hematology conference, and I see that it's got diverse audience. They have outstanding speakers as well as both from Korea as well as outside Korea. Today's morning plenary lecture was outstanding by Dr. Terafi, and I'm looking forward to attending some of the lymphoma sessions. So I would tell young researchers and clinicians that these are really exciting times in hematology and oncology. the advances in science, both in the laboratory side as well as in clinical research, is rapidly growing. The number of therapeutic options that are available for patients at this point, and there are the agents that we have available now that are undergoing clinical trials are mostly non-chemotherapy based, and these are either targeted therapies or immune therapies, which allows us to deliver therapies that are less toxic but much more effective. And we are also seeing that lymphoma subtypes such as indolent lymphomas, which are traditionally considered not curable with standard of care therapies and chemotherapies, and now may potentially be curable with immune therapies. So I think I would advise young researchers and clinicians to stay abreast of the latest research that is ongoing both in the laboratory and the clinic, and to participate in doing clinical trials as well as laboratory projects.